My name is Dr. Gabrielle Norrish, and I work at Great Ormond Street Hospital in London. I'd like to thank the organisers for giving me the opportunity to present this data today. Today I'm presenting data from a study entitled Clinical Characteristics and Natural History of Pre-Adolescent Non-Syndromic Hypertrophic Cardiomyopathy. Does age of onset matter? Due to variable and incomplete age-related penetrance, sarcomeric HCM has historically been considered a disease of adolescence or early adulthood. However, retrospective population studies have described that up to 50% of childhood onset disease is diagnosed before the age of 12 years or in pre-adolescence. A recent study from the SHARE registry described the high morbidity and mortality associated with a childhood onset disease, with over 20% experiencing an adverse cardiac event within 10 years of diagnosis. However, age-specific differences in disease phenotype and outcomes are poorly understood. The aim of this study was therefore to describe the clinical characteristics and outcomes of a large international multi-center cohort of children with non-syndromic HCM presenting under the age of 12 years. We formed a retrospective longitudinal multi-center cohort of children diagnosed with hypertrophic cardiomyopathy under the age of 12 years from the International Pediatric Hypertrophic Cardiomyopathy Consortium. This cohort has previously been used to develop the first pediatric-specific risk model for sudden cardiac death in childhood disease and contains data on over 1,700 patients from 39 centers worldwide. Patients were excluded from this sub-study if they had a syndromic or metabolic etiology of the HCM, if they were diagnosed under the age of 1 year, or if they had previous VF, VT, or resuscitated cardiac arrest. And this final exclusion criteria was because the cohort was originally formed to investigate risk stratification for sudden death, so patients with a previous arrhythmic event were not collected. Clinical data was collected from baseline evaluation and during follow-up. This included family history, symptoms, medical therapy, 12-lead and ambulatory ECG, echocardiogram, and interventions that might have occurred during follow-up. The primary study outcome was all-cause mortality or cardiac transplant, and a secondary outcome was a major arrhythmic event, which was a composite outcome including sudden death, resuscitated arrest, appropriate ICD therapy, or sustained ventricular tachycardia. From a total consortium cohort of just over 1,100 patients with non-syndromic childhood disease, 639 were diagnosed between the age of 1 and 12 years, of which 2/3 were male. The age at diagnosis is shown in the graph on the right-hand side. Over 50% had a family history of hypertrophic cardiomyopathy, and this was a symptomatic group of patients, with a quarter of patients having heart failure symptoms. Only 10% reported unexplained syncope at baseline. 40% were started on or had been, at the time of diagnosis or prior to, on beta blockers. This slide describes the baseline phenotype of the patient group. Although the majority had non-obstructive disease, as shown in the graph on the left-hand side, 1/5 had a resting gradient above 30 millimeters of mercury, and 5% had severe left ventricular outflow tract obstruction, as defined as a gradient above 90 millimeters of mercury. 5% had non-sustained VT detected within 6 months of baseline evaluation. Genetic testing in this cohort of patients was performed at the discretion of the treating clinician and as part of usual care. There was therefore variability in the size of panels and testing techniques. It's beyond the scope of this study to describe the yield of genetic testing in this patient group. Nonetheless, 65% of the patients had had genetic testing, and of these, 80% had a variant in a HCM-related gene identified. Patients who had undergone genetic testing did not differ significantly in baseline characteristics from those without genetic testing. Reclassification of variants was performed according to the ACMG criteria for 253 patients for whom sufficient information on the variant was provided by the centre. Over 50% of patients had a pathogenic or likely pathogenic variant identified in the sarcomeric gene, and this suggests that the yield of genetic testing in pre-adolescent disease is as high as in adult onset disease. Patients with a pathogenic or likely pathogenic variant were more likely to have a family history of hypertrophic cardiomyopathy. Almost 1/5 of patients had a variant of unknown significance, and 6 patients had their variants downclassified to a likely benign or benign variant. For those patients with a pathogenic or likely pathogenic variant, the majority had a variant in either myosin binding C or MYH7. A smaller number of patients had variants in thin filament proteins such as tropomyosin or troponin I. Only 11 patients had more than one variant, which suggests that the majority of early onset disease is caused by single gene variants. And a small number of patients also had disease-causing variants in non-sarcomeric protein genes. This could suggest undiagnosed syndromic disease in this patient group, but it also may support the role of non-sarcomeric variants contributing to disease phenotype in children with clinically non-syndromic disease. Patients were followed up for a median of 5.6 years, and over this time, 10% underwent a left ventricular septal myectomy, 3% had a pacemaker implanted, and almost a quarter had an ICD implanted for either primary or secondary prevention. If we move on to look at the clinical outcomes of this group, 42 patients died during follow-up with the cause of death listed on this slide. The most common cause of death was sudden cardiac death, which is in agreement with previous unselected childhood cohorts. 3% underwent cardiac transplant, and there was an overall incidence of mortality or transplant of 1.4%. 10% of patients met the arrhythmic endpoint. This was most commonly sudden death, but importantly, a quarter of events were resuscitated arrests that occurred during follow-up. The overall annual incidence of arrhythmic events was 1.5%. We went on to compare the phenotype and clinical characteristics of this younger group of patients with 568 patients from the consortium who presented after the age of 12 years. There was a similar proportion of patients with a family history of hypertrophic cardiomyopathy in both groups, although a lower proportion of patients had a family history of sudden cardiac death. Younger patients were less likely to report unexplained syncope, which could suggest that there could be age-related differences in patient-reported symptomatology. The degree of hypertrophy was not significantly different between the two groups, but a higher proportion had left ventricular outflow tract obstruction. This could again be explained by undiagnosed non-sarcomeric disease, particularly vasopathies, which typically present at a younger age. However, this difference persisted in subgroup analysis of those with a confirmed sarcomeric variant, so it suggests that age-related differences in phenotype expression exist. The older group of patients had a shorter follow-up, as would be expected. Younger patients were more likely to have undergone a myectomy, in keeping with a higher proportion with left ventricular outflow tract obstruction at baseline. Patients under 12 years of age were less likely to undergo ICD implantation, but were more likely to undergo ICD implantation for secondary prophylaxis. This could suggest a difference in clinicians' perception of risk and management for those presenting at a younger age, as well as also reflect the difficulties in implanting devices, particularly for primary prophylaxis in small patients with a low small body size. The incidence of mortality or cardiac transplant was similar in both groups. The graph on the left-hand side shows the cause of death by age group. The cause of mortality was similar, regardless of the age of presentation, with the most common cause being sudden death. The graph on the right-hand side shows the age at which these events occurred, and you can see that in the under 12, so these shown in blue, events occurred at a younger age, suggesting there's a shift in the natural history to the left for those patients presenting under the age of 12. Similarly, the annual incidence of a rhythmic event did not differ between the two groups, but again, the events occurred at a younger age, as shown in the bar chart on the right-hand side. The graph on the left-hand side shows the type of rhythmic events, and you can see that these did indeed differ between the two groups, and with a higher proportion experiencing a resuscitated arrest in the under 12s, and a higher proportion of appropriate ICD therapies in the over 12s. And this fits with the pattern of ICD implantation that we described earlier. This study has inherent limitations due to its multi-center and retrospective design. This includes missing data and incomplete recruitment of eligible patients. There was variation in assessment and management by center and also by era. The exclusion of patients with a previous arrhythmic event could have introduced potential bias towards those with a less severe disease phenotype. And finally, the age of diagnosis for an individual patient is determined not only by disease-related factors, but as we know also by local healthcare screening and healthcare system factors. This could have introduced unmeasurable bias in the patient cohort. In conclusion, pre-adolescent HCM is associated with a high symptom burden and variable cardiac phenotype that is comparable to those presenting later in adolescence. As such, similar management strategies to older patients should be used for this group, including the future use of disease-modifying therapies. Long-term mortality outcome did not differ by age of presentation, but those presenting under the age of 12 years experienced events at a younger age. And the instance of instance of arrhythmic events did not differ by age of presentation, but those under the age of 12 years were less likely to receive a primary prevention ICD and to experience resuscitated arrest during follow-up. So this study suggests that pre-adolescent patients should not be considered a distinct entity for risk stratification. I'd like to finish by thanking all the co-investigators in the International Pediatric Hypertrophic Cardiomyopathy Consortium, without whom all this work would have not been possible. And thank you very much for your attention, and we're happy to answer any questions.